I'd like to thank SAGES for the opportunity to present our work. My name is Sharbel Elhage, and I'll be presenting on the impact of perforator sparing on anterior component separation outcomes in open abdominal wall reconstruction. Here are our disclosures. Ventral hernia repairs are one of the most common procedures performed in the United States. A tenet of hernia repair is fascial closure in an attempt to restore anatomy and decrease hernia recurrence rates. In patients with large ventral hernias requiring abdominal wall reconstruction, fascial closure can often be difficult or impossible to achieve without utilizing a component separation technique to achieve increased release, especially in large ventral hernias or patients with loss of domain. Popularized in the 1950s, the anterior component separation allows for the greatest amount of fascial release, but requires large subcutaneous flaps to be raised in order to access external oblique aponeurosis. This was a 19 by 27 centimeter fascial defect which was not able to be closed. By using an anterior component separation, this patient was able to have fascial closure and has gone on to do very well with long-term follow-up. However, one of the problems with standard anterior component separation is the large skin flaps required to adequately access the external oblique aponeurosis. We elect to perform an anterior component separation preferentially over a transversus abdominis release if there is a large defect when there is a 6 centimeter gap remaining between the fascial edges after bilateral posterior rectus sheath release. Wound complications have been shown to be a strong predictor of hernia recurrence. In an evaluation of over 1,000 ventral hernia repairs with mesh, surgical site infection significantly increased the odds of requiring mesh explantation. In order to prevent such outcomes, perforator sparing techniques have been introduced. First popularized by Chuck Butler, these techniques allow for preservation of perforating vessels into the abdominal wall and allows for continued perfusion to the flap in an attempt to mitigate wound complications. In 2015, we began utilizing the perforator sparing technique whenever possible with meticulous dissection of the epigastric perforating vessels. This is done by either tunneling laterally and dissecting around the perforating vessels or maintaining a wedge of fat from approximately 2 centimeters above and 5 centimeters below the umbilicus. Once the vessels are identified, the dissection can then be carried superiorly and inferiorly to expose the external oblique aponeurosis. The aim of our study was to evaluate the outcomes and specify wound complications of standard ACS with wide skin flap mobilization versus perforator sparing ACS or minimally invasive techniques in patients undergoing open abdominal wall reconstruction. Using our single institution prospective hernia database, all patients undergoing anterior component separation as part of abdominal wall reconstruction were identified. Patients undergoing concomitant paniculectomy were all placed in the standard anterior component separation group. The primary outcome of interest was wound complications, and the secondary outcomes include postoperative complications, length of stay, and hernia recurrence. In total, there were 252 patients who met our inclusion criteria. 228 underwent standard anterior component separation, and 24 underwent perforator sparing. Patient characteristics were largely similar, although the perforator sparing group did average nearly 2 more comorbidities per patient and had higher rates of history of tobacco use. BMI and number of prior hernia repairs were similar between the groups. Rates of recurrent hernias and hernia defect size were similar. However, the perforator sparing group was much more complex, with higher rates of ventral hernia working group grade 3 and 4 hernias, and higher rates of incarcerated hernias when compared to the standard ACS group. Mesh size and mesh placement were similar between groups, with the vast majority of mesh being placed in the preperitoneal space. This allows for placement of a very large piece of mesh while maintaining exclusion from the intra-abdominal contents. Rates of bilateral anterior component separation were similar, as was operative time. Per our inclusion criteria, all paniculectomy patients were in the standard anterior component separation group. The perforator sparing group was much more likely to have undergone planned delayed primary closure, as this management technique has been more recently implemented. Overall wound complication rates were much lower in the perforator sparing anterior component separation group at 21% versus 46%. When broken down into specific wound complications, seroma requiring intervention, cellulitis requiring antibiotics, superficial wound breakdown, wound infection, and mesh infection rates were all similar between the groups. To ensure that paniculectomy patients were not heavily influencing the rate of wound complications in the standard ACS group, those patients undergoing standard ACS with concomitant paniculectomy were compared to standard ACS patients who did not undergo paniculectomy. Overall wound complication rates were similar between these groups, as were seroma requiring intervention, cellulitis requiring antibiotics, wound infection, and mesh infection. Only superficial wound breakdown was higher in the paniculectomy group, possibly due to the much larger transverse incision required for a paniculectomy and increased tissue undermining. Other postoperative outcomes were also evaluated and were generally similar between the groups. Length of stay was high in these complex patients, but all other hospital complications, including return to OR and readmission, were similar. Hernia recurrence was lower in the perforator sparing group, but not statistically significant, likely due to the small sample sizes. In conclusion, perforator sparing anterior component separation technique leads to decreased overall wound complications compared to a standard ACS technique. Our study was unable to show a statistically significant difference in recurrence rates, but future studies with larger sample sizes of perforator sparing patients may be able to show improved recurrence rates over time. We conclude that perforator sparing anterior component separation should be used preferentially over standard anterior component separation if possible. Thank you.